Hello, and welcome to another live broadcast with MedStar Health. Did you know that heart disease is the leading cause of death for women in the United States? Despite increases in awareness over the past decades, only about half of women recognize that heart disease is their #1 killer. So today we're going to learn about risk factors, understand the non-traditional risk factors, and steps to keep your heart healthy. We're live today with cardiologist Dr. Azifi, Dr. Shrishi, and Dr. Jean discussing women and heart disease. If you have questions for our experts, ask them in the comments below and we'll be sure to ask them. Also give us a like, let us know you're watching, and share this broadcast with your friends and family so we can help spread the word about heart disease awareness. So before we begin our broadcast, our experts will introduce themselves to you. Let's start today with Dr. Azifi. Can you introduce yourself to our viewers?
Hi, I'm Ijoma Izifi. I'm a non-invasive cardiology specialist. I'm a heart specialist here with MedStar in Baltimore. It's very nice to meet you guys and talk about heart disease today.
Thank you. Dr. Shrichi?
Hi, my name is Dr. Barbara Shrichai. I am at the Georgetown site of MedStar, and I've been here for about 8 to 9 years. And my specialty interests, I'm a non-invasive cardiologist as well. My specialty interests are in advanced cardiac imaging and women's heart disease.
Thank you very much. And Dr. Jean, can you introduce yourself? And you're on mute.
Yes. Hi, I'm Dr. Estelle Jean. I've been with MedStar since 2013, practicing as a non-invasive cardiologist, and my interest is in women and heart disease and pregnancy-related complications. And I'm really excited to be with you today to discuss the women and heart disease.
Okay, thank you all very much. We really appreciate your time, and we're looking forward to educating our viewers about women and heart disease. So let's get into some questions. So Dr. Shrichai, can you start by talking about what should women know about heart disease?
So that's a great question. First off, I would say, what do we mean when we say heart disease? I think most of us out there think of, the classic heart attacks, and we think it's a man's disease. But when we think of heart disease, we actually think of it, we call it more generically cardiovascular disease, because we're thinking about diseases that affect both the heart, but also the blood vessels. In addition to heart attacks, which is kind of like the extreme end of things, I think we think about diseases that also affect the heart muscle, like weakened hearts, plaque buildup in the heart arteries that can then lead to a heart attack, heart valve issues, heart rhythm issues. I just asked my mom today, do you have heart disease? And she has a heart rhythm abnormality, but she told me no. And I was like, no, Mom, you do have heart disease. You have a heart rhythm abnormality. So I think that's an important point, is just what do we mean when we're talking about heart disease? Because it does encompass a wide range of features. A lot of people often think it's a man's disease, but there are specific aspects of heart disease that are more predominantly women focused. And I think we're going to go a little bit more into that detail with our other questions.
Yep, thank you very much. That's really important to know. What is MedStar Health doing to address the specific needs of a woman's heart?
So we have developed the MedStar Health MedStar Women's Heart Health Program. It was launched about 3 years ago, actually February 2019. And the purpose of the program, our mission, is to increase the awareness of cardiovascular disease in women in the DMV area, as well as educate women about their own personal risks, and give resources to women who identify themselves at an increased risk group based on their personal risk factors, including female-specific risk factors. So to this end, MedStar has created several different platforms to increase the awareness, one of which we're participating here with a live Facebook feed. In addition, we have a website that is dedicated to our program and actually offers information in the form of a heart quiz, a personalized heart health quiz specific for women that anybody can take, and helps you identify your own personal risk, and then gives resources in terms of what to do with the results now. How do I speak to my doctor about these results? When should I be making an appointment with a cardiologist? How would I do that? And we hope to update with more kind of educational information on the website to help our female patients.
Great, thank you so much. Dr. Azifi, what role, if any, do hormones play into a woman's risk for heart disease?
Hormones play.
Does someone else want to answer that one while she's?
I think
Here she is. Okay.
Yeah.
I apologize. For some
No
reason,
problem.
a phone call came through the landline. Hormones play a significant factor in women's heart disease and different phases of women's lives. We have different sort of hormonal balances, and in those different phases, we are at different risks for specific heart disease. So, for example, I would like to talk about menopause and also pregnancies, for example. Menopause, as we know, is basically a conclusion of the reproductive phase of a woman's life. There are significant changes in the hormonal balance in the woman. And during this period, there are significant changes in a lot of factors that end up being players in development of heart disease. First and foremost, having menopause at an early age does increase women's risk for heart disease. And when I say heart disease, I mean both heart failure and having clogged arteries, which is what we call coronary artery disease. This is basically when we have blockages in the vessels that bring blood to the heart, and therefore blocking those areas causes what we know as heart attacks. So menopause is a time when the bad cholesterol in the body tends to go up. The blood pressure tends to go up. Women's waist circumference, you meet a lot of women and they'll be like, I always maintain a very healthy weight all my life. And, suddenly with menopause, I'm beginning to have like a change in distribution of fat and begin to have more fat around my midsection. This is the dangerous fat, the fat that tends to stay around the organs, tends to cause more inflammation, and sort of increase the risk of heart disease, heart attacks, etc. So there are a lot of hormonal changes with menopause that sort of make women catch up, in a sense, to the amount of heart disease that men traditionally have always had. So the menopause transition period is a period where a lot of women who never had heart disease will now get factors that put them at risk. And if proper preventive measures are not put in place at that time, they then will start to exhibit symptoms of heart disease down the line. Pregnancy is another time where hormones and hormone balances can change how a woman's cardiovascular health is going to go forward. Pregnancy is a time of high stress in the body, high stress to the heart. The body is growing a second being, and at that time, there's more blood available, there's more work the heart has to do to not only support mommy, but also support baby, basically. And as a result, if there was any kind of weakness that the heart muscle may have had that was not apparent, it can become apparent with pregnancy. Women can develop, new high blood pressure, new high sugar levels, things that can, in the long run, put them at higher risk for having heart disease during pregnancy, all as a result of the different hormones and different changes that the body has to go through to be able to have a successful pregnancy. And so, in that sense, the hormones do play a huge role, as you can see in these different phases of a woman's life.
Yeah, that makes a lot of sense, that those changes could, they're big changes that happen to our body that can affect how things are for the rest of our lives. And you talking about stress on the body, I almost had, flashback to when I was pregnant, growing two babies, actually.
Oh, wow.
So yeah, extra stress. I don't know if that makes a difference for me for heart disease, but growing more than one baby, it certainly adds a lot of stress, and hormone levels, I'm sure we're all over the place. Well, thank you, Dr. Azifi. You touched on this a little bit, but can you talk about why women have a higher risk than men for heart disease?
So in general, we have always thought as men being higher risk of heart disease, and in some cases, in the share population sense of all comers of heart disease, men probably still have more heart disease, but there are specific types of heart disease where women are coming out, unfortunately, to have more of them. Over the past few decades, the type of heart problems we're seeing are changing. Before, we used to have more of the heart disease where the heart muscle was very weak and could not push out blood to help with daily activities, so people are short of breath and things like that. Nowadays, we're beginning to see a new kind of heart failure, which is where the heart is pumping just fine, it pushes the blood out just fine, but it's just not able to relax and take in blood. And if you can't take in blood and you're taking in less blood, then you're putting out less blood for the body to use to do its daily activities. Women do have a much higher risk for developing this type of heart disease we call heart failure preserved ejection function, which is a lot of garbage, but pretty much the long and short of the story is that the heart muscle is stiff, the heart muscle is strong, but the heart muscle is not able to relax and take in enough blood to get to our daily activities. And so that kind of heart problem is very, very it's more in women, and it causes a lot of symptoms, and it's something that we do not have specific treatment for. And so that's something that is sort of troubling, that we are beginning to see that this is happening. The reason why this is happening, we don't have like a true cut answer of this is it and this is the only issue, but there are many factors that sort of contribute. One is higher blood pressures, or pressures that are not treated aggressively. Women may have, problems with the rhythms, the heart rhythms that can cause this kind of issue. Being heavy set or obesity is a contributor to this particular type of heart disease. And not identifying the risk factors early enough, either in pregnancy, sometimes pregnancy tends to be a forgotten time. You have the pregnancy experience and, it's stressful and you sort of put it in a box somewhere. But that box sort of follows you. We now have a lot of research that shows that you can't forget what happened in pregnancy, the high blood pressure, the high sugars. Those are sort of markers. Those are sort of warning signs, red flags, if you will, to let us know how things are going to play out down the line. And so we need to do better. That's the summary of this. We need to be able to identify these risk factors and treat them aggressively as they happen. Pretty much.
Thank you very much. And we're going to talk more about risk factors in just a moment with Dr. Jean, but I do have some questions coming in from our audience members. So I wanted to take a moment to ask those. This first one is from Mary. Mary, thank you for asking your question. And this is for any of you. She is asking to explain what LBBB, or left bundle branch block, is. I know we haven't talked much about that specifically, but if you could talk about how that relates to heart disease, Dr. Shreechi, that would be great.
Okay, sure. So,
or was that Dr. Jean? I'm sorry.
Dr. Jean.
That's right. Yeah.
Okay.
I mean, so left bundle branch block is, we kind of consider it, we call it a conduction abnormality. It just means the electrical signals that go through the heart that tells it to contract. It's going in a funny manner. So it's taking a longer period of time to get the signals to the muscle. So the muscle doesn't quite squeeze as quickly as it might if you didn't have that. We say it's a marker for something structural going on in the heart. As we had mentioned, heart attacks are always one of the things we get worried about the most, because it is one of the more common diseases we see, particularly in men with heart disease. And a left bundle branch block can be a marker of that, especially if it's new. But it can indicate a lot of other, it's a finding that we see on the EKG. It's it can be somewhat non-specific. So just because you have it doesn't mean you're having a heart attack. It could be a lot of other things that can cause that. And I don't know, Dr. Jean, if you wanted to expand on what I've already said.
No, you did great. Yeah, I mean, it's an electrical issue. Commonly, it's wear and tear. So there's a main electrical highway that gives the electrical information to the top and bottom chambers of the heart. And so the left bundle branch, that's just a name that we have for one of the exits, that sometimes with age or clogged arteries or heart muscle problem, where that exit just wears and tears. So sort of what I usually tell my patients is, think about you're taking a main highway, but then you have to take an exit. So if that exit gets closed off, what do? You just take the next exit as a detour. And whenever you take a detour, you always get to your final destination, but it just takes a little longer. And so when we're looking at the electrical cardiogram, that's what we're seeing. We're seeing that little exit that had a little bit of a wear and tear along the way, again, due to either a structural issue with the heart or just age. And then we usually do some additional testing to look at the other components of the heart that we've mentioned. So is it a heart muscle problem that's contributing to this? Is it a heart valve problem? Is it a clogged arteries? And that sort of completes the full assessment. But the key is, if you have that diagnosis, make sure you let providers know of that diagnosis. So if you go to the emergency room with chest pain, then we sort of think about it differently, because we know it's an old condition.
Okay, thank you both for answering that question. And thank you, Mary, for asking the question. We have another one. This is from Star. She asks about LDL and heart disease. How concerned should I be with high LDL? And if you could talk about LDL and what that is first, and talk about that in heart disease, that would be great. Dr. Jean, did you want to answer that one?
Sure, yes. So when we think about cholesterol, we look at different components. So there's the total cholesterol it's comprised of your good cholesterol, your HDL, the happy one we think about, that's the good one. And then there's the bad cholesterol, the LDL, the low density or the lousy. And there are other components of that total number as well. But we focus on the LDL frequently because that's the one that tends to, when it's in excess, gets embedded, or it's within the arteries of the heart, that then eventually can cause hardening of the artery or plaque buildup. But what's interesting is it's complicated. That's not the only thing that we sort of think about when we're assessing a woman's individual risk, because the HDL is an important number as well. So because of the impact of estrogen that was discussed earlier related to menopause, women were supposed to have a high HDL. So one of the things actually I do when I assess my female patients is also consider the HDL, because if the HDL is low, that actually has been found to be a better predictor for women compared to the LDL, because a low HDL plus a high triglyceride overall tends to show that the woman is at higher risk for developing heart disease. So we do have to look at all the numbers when we sit down with you to figure out what that LDL means in the context of your lifestyle, again, the HDL, triglyceride, your smoking history, and try to put the whole story together to understand what your risks are. But generally speaking, we want the bad cholesterol, the LDL, to be less than 100. And if it's above that number, then of course we think about lifestyle, and then maybe some other testing, which we'll talk about probably later, such as a calcium score, to truly understand your risk for heart disease.
Thank you very much. I have one more audience question, then we'll get into risk factors. This one's from Gail, and we haven't specifically talked about the Watchman, but she is interested in hearing about it. What about the Watchman? I may get one. Maybe this would have been addressed a little bit later. Is that a treatment option? Can you talk a little bit about that? Who wanted to take that? Dr. Srichi?
Sure.
Okay.
The Watchman, so the Watchman device, so now you're talking about an interventional procedure that it's not focused only on women. It's more, can be men and women, but it's a specific treatment that we apply in patients who have a heart rhythm abnormality, such as atrial fibrillation or atrial flutter, that puts them at increased risk for blood clots to form in the heart in specific areas of the heart. And then the Watchman in patients who can't tolerate a blood thinner, either bleeding, it just causes too much bleeding, or they're at risk for falls that could increase the risk of having bleeding because of the fall. Looking at other alternatives to kind of decrease that risk of having blood clots form in the heart, and blood clots can then cause things like strokes that we want to avoid. And that's probably one of the biggest risk factors in patients who have heart rhythm abnormalities such as atrial fibrillation, that again puts them at increased risk for blood clots to form. So the Watchman device is one. I mean, there's been several types of therapeutics out there to kind of address this, but this is we say non-surgical approach to mitigate some of that risk. You do have, and it basically kind of blocks out the areas where the blood clots tend to form, which is the left atrial appendage. So the left atrium is the part of the heart that is not contracting normally or just regularly when your heart is out of rhythm. It's instead of kind of like doing a coordinated squeeze, it just kind of like moves around, fibrillates. That's how we sort of get that word fibrillation. And there's a certain area, and I called the left atrial appendage, that is where some of the blood clots tend to most likely occur. And then the Watchman device tends to close that area off.
Okay. Thank you very much. Thank you, Gail, for that question. Thank you to all of our viewers who have joined us. If you are just tuning in, we are talking about women and heart disease with cardiologists, Dr. Izifi, Dr. Shrichi, and Dr. Jean. We're going to talk more about some risk factors. And if you do have any other questions, please post them in the comments. We're going to get those in as well. So Dr. Jean, let's talk about risk factors. What are the risk factors for heart disease, just in general, and what are the ones that are specific to women?
Yes, so we do break up the risk factors into the ones that you can control and the ones that you can't. So we can start off with the ones you can't. So that would be age, that would be hereditary. So if there's a family history, we can't control that, and gender, as well as race. Now, the ones that we can't control is definitely sort of the butter of prevention, because it really can go a long way at overall reducing your risk for heart disease and stroke. And so when I tell my patients, at the core of heart disease, though, is inflammation. So what are the risk factors that make our body more inflamed? So we know high blood pressure, high cholesterol, smoking can contribute to having an environment where more plaque can form, but as well as being overweight. So, we've seen the impact of weight in many diseases such as COVID, right? So that when patients are overweight or obese, they are more likely to get severely ill. And the same applies when it comes to your heart health through sort of the pathway of inflammation. Diabetes is an important risk factor because that blood sugar kind of acts as a syrup that can clog up the arteries of the heart. And so it's important to make sure that you have good blood sugar control so that you can reduce your risk, as well as alcohol. Now, there are some studies that show the benefit of the Mediterranean diet, but you do want to limit your alcohol intake as a woman to no more than 4 ounces a day of wine or 1 beer or 1.5 spirit, because in excess, that also can increase your risk for having heart disease. Now, other key risk factors that we know in women, we also have to consider is stress. Because when we're stressed, our body also is much more inflamed. And so that chronic stress that many of my patients have been experiencing during COVID can increase your risk for heart disease. So again, to summarize, sort of the key ones are high blood pressure, high cholesterol, smoking, being overweight, excess alcohol, and diabetes are important risk factors when we consider an individual's personal risk for heart disease.
Thank you. And I really like the stress one too. And everybody just deep breath who's watching right now, just release that stress. That's very, very important too. Thank you, Dr. Jean. Let's talk about why do women present heart disease differently than men?
So actually, this has been a really interesting area of research. And Dr. Hashim, he's one of the interventionists at MedStar Washington Hospital Center. And he actually has been able, through collaboration, make Washington Hospital Center a center of excellence, looking specifically about women and heart disease and how our symptoms can present differently. And a key component is at the level of the blood vessel. So many times, for years, we really have been focusing on the major arteries of the heart. But when we sort of quantify what percentage of the big arteries supply blood flow to the heart, it's only 5%. The majority of blood flow is within that 95% that an angiogram or cardiac catheterization really doesn't show us. But what we are learning, though, is that women more frequently will also have blockages within the smaller arteries of the heart. So they do have blockages like men in the major arteries, but it's the smaller arteries that tend to get clogged up through many of the risk factors that I talked about. And so because women tend to have the blockages and the narrowing, as well as hardening or stiffening of the arteries in the smaller vessels, we tend to present a little bit more atypical in terms of symptoms. So we tend to have a little bit more of the shortness of breath when we're doing our activities, or fatigue, racing heart rates, as well as arm pain. Typically it's in the left, but you can also experience it in both arms, or shoulder pain, as well as the jaw and the throat discomfort. And so it's been really exciting to learn more about this condition, which we call small vessel heart disease, or coronary microvascular disease, to really sort of give credence to a lot of women in their experience, where they, have chest discomfort, they know something's wrong, but many times they might have sort of a normal cardiac evaluation. But with more of the advanced testing, we're able to now create a better treatment plan to figure out how best to alleviate or to treat many of their symptoms, and to be much more aggressive with the risk factors. Because now that we're understanding that the little arteries are also prone for getting clogged, we can be much more aggressive with their risk factors and treating their cholesterol and other conditions that before we wouldn't have, because we're focusing mostly in the big arteries, where a lot of times in women, they tend to be within the normal range. So that is definitely an area of more research that we're doing, with more advanced cardiac testing that is offered within MedStar Washington Hospital Center, for us to give a much fuller, holistic, comprehensive approach to the chest pain evaluation.
Thank you very much. So you talked a little bit maybe already about the warning signs. So the shortness of breath, fatigue. Are there any other warning signs of heart disease that are different for women versus men?
Yes, so women can also experience back discomfort, or a description of indigestion, or discomfort in the upper abdomen. And it can happen at rest. So women do tend to have a little bit more at rest or in the middle of the night compared to men, as well as, the palpitations or the racing heart rate. But definitely, by far, percentage-wise, the number one presenting symptoms is still chest discomfort. Most of my female patients will correct me and tell me it's not pain. So they will experience more of a pressure, tightness, a sharp discomfort. But we do more commonly see some of the atypical symptoms in women compared to men.
Thank you. And as a physician, how do you assess women for heart disease differently than men?
Yes, so the calcium score definitely is one of them. So if I see a female patient who may not have high blood pressure or diabetes, but there's a strong family history of heart disease with a little bit borderline cholesterol numbers, I'm more likely than not to offer them a calcium score to better assess their risk factors, because some of our older ways of testing patients with what we call the calculator, so the Framingham-Risk calculator, sometimes can underestimate the risk, especially when there is a family history of early onset heart disease. So the calcium score is an important way to help understand your personal risk better, and seeing what areas that we need to be more aggressive with. And as well as what I mentioned, in sort of collaboration with some of the interventionalist doctors at the hospital center, to do more of those advanced testing with special wires with that angiogram, to see if maybe the chest pain is due to the smaller vessels of the heart so that we can, again, be more aggressive with treating many of their risk factors with lifestyle changes, as well as certain specific medication to help improve the blood flow so that they have less chest pain symptoms.
Can I just
Thank you. Yeah, go ahead.
I just wanted to also bring up, in addition to what Dr. Jean has mentioned, to pull in, I also specifically asked my female patients their women's heart health, their women's specific history. Have they ever been pregnant? Are they, when did they get menopause? Was it early? Were they on hormone replacements? Because as was pointed out earlier, that plays a large role into their personalized risks, which isn't one of the traditional risk factors that we think of, but does certainly add to a woman's personalized risk compared to a man. So that is, I wanted to just make sure that we bring that into as well with regards to the hormones and pregnancy.
Yes, and thank
Yeah,
you so much for adding that part. And another part that I forgot to mention is about autoimmune diseases. So we definitely need to put into consideration if there's a history of rheumatoid arthritis, of lupus, because again, these conditions can make the woman more inflamed. And we also need to consider the history of polycystic ovarian disease, because that as well as a recognized potential risk factor. So yes, a much more comprehensive assessment in both early years, during pregnancy, menopause, as well as autoimmune diseases.
And then let's not forget breast cancer, because obviously a history of breast cancer and treatments for breast cancer can affect a woman's overall long-term risk of heart disease.
Thank you very much. That's all very important. And just reminds me to invite our audience members to share this broadcast with your friends and family, especially if you know of a family member who has had breast cancer. They might not be thinking about their heart health. If they have an autoimmune disease, they might not be thinking about their heart health. So make sure that you are sharing this broadcast, because maybe menopause, pregnancy, all of those things we've talked about are factors in this, and we're not always thinking about it. So please share this broadcast. So thank you all for that. That was really helpful. Just to close out our risk factor conversation, then I'm going to ask you some audience questions. What are your recommendations for reducing the risk factors of heart disease in women? Dr. Jean, do you want to start?
Yes, so the weight definitely is a big one. So unfortunately, COVID has been challenging as we're working from home and just losing steps in the process and not being active. Many of my patients are gaining anywhere from 5 to 20 pounds. So working on losing some of the weight that we gained during COVID and getting back into that normal weight range, and as well as the abdominal waist circumference range, which for a woman is less than 35, can significantly reduce your risk. And limiting your alcohol intake to no more than 1 beverage. Quitting smoking is important. So after quitting smoking for 1 year, you can reduce your risk by 50%. And then within 5 years, you're back to sort of a normal risk assessment when we don't necessarily consider smoking any longer. And of course, exercise, aiming for at least 2.5 hours a week of moderate intensity exercise and 2 days a week of strength training, as well as a plant-based or heart healthy diet, limiting your processed food, as well as foods that are high in saturated fats and processed food. Stress is crucial, and that ends up being an important conversation I have with many of my patients. So in meditation, yoga, therapy if needed, medications to help us balance the many roles that we're playing in our lives during this transition, and as well as making sure that you're staying connected with friends and loved ones, because the social isolation during this pandemic has really been detrimental to many of my patients' health, and we know the impact of social isolation can on our mental health, so anxiety, depression, making sure that those are treated, because that link between mental health and cardiovascular health is strong. And so we want to make sure that we're doing okay from that perspective as well.
Sure. Yep. That is great advice. Thank you so much. So I have some audience questions to ask you. The first one is from Donna. This came in before our broadcast. Wanted to ask, should I see a cardiologist? Her mother died at 64 of a heart attack. Her brother died at 43. Sorry to hear that, Donna. His heart stopped. Both of them smoked. So you talked about smoking, Dr. Jean, earlier. My oldest brother has had a heart attack at 59 and has had 3 stents. So do we should Donna see a cardiologist given the family history that she has?
Yes.
Dr. Zifi?
Yes, so Donna should see a cardiologist because there is a lot of value in preventive cardiology. We have here Donna's family, very high, very high risk family history, multiple relatives with significant heart disease. So we already have a suspicion of some sort of genetic predisposition for Donna to have heart disease. And so in a patient like Donna, if she was to see me on my first visit with her, we will go through her entire history, trying to identify the risk factors that exist for her, starting from the weight, the blood pressure, the experiences during pregnancy, the age at menopause. If she had, a surgical menopause, for example, that's another risk factor. Like if she had her ovaries taken out young or things like that. Go through, her habits, how much exercise is she getting, smoking history. All these things will give us a picture of the environment Donna is living in now, separate from her genetics. And then we would obviously try to get her cholesterol checked. We would have a baseline electrocardiogram where we can see her electrical cardiac rhythm pattern to see if there's any evidence of any prior damage. And oftentimes, depending on what we find from this workup, we may end up doing the calcium score, which has come out and is very powerful in patients like Donna, to let us see if she has some heart disease. On that data, she has the test done. And if we do see some heart disease, we can then aggressively treat in the hopes that she doesn't go down the same pathway that her family members have gone down. So yes, it is valuable to have a cardiologist's input because we can achieve a personalized, tailored approach to preventing heart disease for her, and really, go down to the nitty-gritty and make sure that we, approach her care in a very comprehensive fashion.
Thank you very much. I have another question from Rhonda. She says, now that I've been diagnosed, now what? She says, initial vascular study concluded 60 to 79% blockage at the corticoid artery and blockages in and around the heart, awaiting additional tests. So if you are diagnosed with heart disease, what is next for patients like Rhonda?
I guess I can take that one.
Okay.
So yes, I mean, the first part is awareness. And so it's good that Rhonda went and saw a physician and has diagnosed that she does have underlying atherosclerotic disease, which affects the blood vessels. I mentioned heart disease. We think about the blood vessels in addition to the heart itself. So what do we do with that now? Well, we work on, just as if we didn't know she had anything, we would still work on all her risk factors: healthy lifestyle, healthy diet, exercise regularly, normal weight. But we would then also incorporate medications that might help reduce her risk for creating further plaque burden. So she already has plaque that we see. She may have the beginnings of plaque elsewhere that if we didn't address right away could progress. And so we want to prevent that, because if plaque progresses, it can lead to further blockages, lead to symptoms and heart attacks in the future. So we want to be aggressive about addressing the underlying risk factors that she may have and making sure we're adequately addressing and treating each one to prevent further events, heart attacks or strokes.
Thank you very much. That's a good segue, Dr. Srichai, to my next question. This one's for you. What advice do you have for women to proactively discuss their heart health with their primary care physician?
Well, everybody here obviously is here and for a reason, and they're concerned about their underlying heart health. And if you feel like you're at increased risk, or you just even want to know kind of like what your underlying health risk is or heart risk is, I would absolutely speak with your primary care physician and ask them, do you think I'm at increased risk? What are my risk factors. This is what I've learned, and this is what I'm concerned about. Should I be seeing a cardiologist? Because some patients may need referrals to go to a cardiologist from their primary care, but there are a lot of primary care physicians who are very educated in women's heart disease as well, and can provide a lot of feedback and important information about your personal risk, and can manage some of the things that we've been talking about here. But if you feel uncomfortable at all, I mean, with what your underlying risk is, first speak with your primary care, and then go on to a cardiologist if you feel like there's increased risk there that you want to investigate. We see patients with heart disease every day. Primary care specialists see patients with all types of diseases, including heart disease. So some of the subtleties may be picked up a little bit more with someone who sees heart patients all the time compared to a primary care doctor. So just kind of like balancing the two, but absolutely any resource you have physician wise, absolutely bring it up if there's any concern at all.
Thank you very much. So you touched on this a little bit, but can you talk a little bit more about when is the right time for a woman to see a cardiologist?
As I mentioned, if you have any concern about your underlying risk, and we talked about, I already forgot her name, was it Donna or Rhonda?
Yeah.
That should absolutely, someone who's considered at high risk, has a family history. I would say, if you have any concern and you feel like it's not being addressed appropriately by your primary care physician, then I absolutely would then seek somebody who has more experience and expertise in that area, because as I mentioned, there could be subtleties that a primary care physician may not realize and may not appreciate. And then if you have known heart disease, whether it be a heart rhythm abnormality, whether it be underlying plaque buildup in your arteries or a cardiomyopathy, you should be followed by a cardiologist. I think primary care doctors are great, but they have so many things on their plate, and having somebody that's going to be focused on your heart when you have known underlying heart disease, I think that's very important. I don't know if my co-moderators have their own thoughts in that regard as well.
Yeah, I mean, I think one benefit is the time component. I think primary care doctors are just doing an amazing job, but they just don't have the time that maybe a consultation, like a 30 minutes, just to talk about your cholesterol, like what can you do, so there can be benefit to that. It's always a tough question because in cardiology, we don't necessarily have set guidelines like we have for your pap smear, for mammograms, for colonoscopies. And it's just the way sort of the disease is, because it is sort of this inflammation which can occur with so many lifestyle component that makes it a little bit harder to say, at the age of 50, you need to have a stress test. Because one of the things that we learn is just because there's a plaque doesn't mean that if we fix that particular plaque in someone with no symptoms, that we're guaranteeing that we're going to prevent a heart attack, because many times it's the other little ones that we didn't fix, but the person didn't change their lifestyle. They kept smoking, their diabetes isn't well controlled, their blood pressure is not well controlled. And so then that little plaque ends up causing a problem down the line. And so, in cardiology, sort of that integrative approach with lifestyle, medications where it's appropriate, of course, working very closely with the primary care doctor, with, of course, the patient at the center, to come up with the best plan while we're treating all of the risk factors to the best that we can.
Thank you both very much. Let's talk about treatments. We have an audience question about that as well. What are the treatments for heart disease, and how are they different in women than men? Dr. Srichai, do you want to start with that one?
Sure. So as we first discussed, when we talk about heart disease, there are a lot of different types of heart disease. The most common one would be blockages in your arteries that we talked about, atherosclerotic disease, that when the blockages progress can cause heart attacks. And the treatments for that don't really vary between men and women, except if we don't see any significant plaque buildup and we're considering that a patient may have microvascular disease, as Dr. Jean had pointed out. We are still sort of investigating what the best treatment options are in those cases. A woman having chest pains but having no big vessel plaque buildup that we can see, but now we're focused on the small vessels. So we're treating them similarly to how we do the big vessels, but there are investigations ongoing. One of which I'll mention that we are a part of is the Warrior trial, which is looking at women who have, we say, non-obstructive heart disease, coronary artery disease rather, and looking at traditional kind of therapies, which is kind of what your doctor would normally prescribe for men or women, and focused treatment therapies, and seeing whether one is more beneficial than another, specifically in female patients. So I think when we say, you know, are they different or not? So depending upon what the underlying cause of disease is, and that varies again between men and women, will determine sort of what the underlying treatment is. But then even there, we're a little bit open in terms of what the best treatment is specifically for women when they don't have what is normally what we see in men. I don't know if either of you guys want to elaborate on that.
Yeah.
There were two other conditions I forgot to mention about, a little bit more specific for women. So one of it can be that occurs more frequently. So broken heart syndrome. So that one we see typically after a stressful event. So it could be the death of the family or after surgery, where there's just this significant increase in adrenaline hormone that causes the heart to break, or it doesn't work well. And women can present with chest pain, heart attack symptoms, congestive heart failure. But when we do sort of that angiogram, the arteries are okay. And then usually once you remove the stress, a few weeks later, the heart gets better. So in those particular cases, we really sort of focus and hone in on stress management, as well as continuing a medication like a beta blocker to keep those adrenaline levels lower. And other things that we also have found are a little bit more frequent in women, especially around the change of hormonal status, is the tear in the arteries of the heart, which we call spontaneous coronary artery dissection, or SCAD. There's a registry that has been following these patients, you know, over the past several years to figure out the optimal way to manage these patients. So, and usually that's made at the time of the angiogram to figure out if it is a tear in the arteries of the heart. So these are sort of a little bit more common in women, broken heart syndrome and SCAD, but that would be under the care of your cardiologist to figure out the best treatment for you moving forward to prevent a recurrence.
Thank you. I have a treatment question from Betty. She asks, does tachycardia go away totally after treatment with beta blockers? Oh, who would like to answer? Dr. Srichai, would you like to?
Sure. So it depends upon the tachycardia and what the underlying causes of the tachycardia. When we think about tachycardias, and first off, tachycardia, all that means is the heartbeat is going faster than it should. And we do put usually a cutoff of 100. If it's above 100, we usually then term it as that's faster than a heart should be going at rest. It's normal when you're exercising, but at rest, it shouldn't be really running that fast. It's kind of like your heart's on overdrive. So depending upon what the underlying heart rhythm is it just a normal sinus tachycardia, or is it associated with a heart underlying arrhythmia? So there are different types of tachycardias, and the treatment will vary. So beta blockers are a common therapy that we use in a lot of these tachycardia rhythms. But again, as I mentioned, it could be physiologic and just a normal sinus tachycardia. But if the reason it's there is because of something like anemia or fevers, a beta blocker is not, you know, it's there, your body's telling you something, it's doing that for a reason. And trying to suppress it is not fixing, we try and fix the underlying cause. So if your blood levels are low and that's what's causing the tachycardia, the solution isn't just putting you on a beta blocker, it's fixing your blood levels. If you do have a heart rhythm abnormality, beta blockers are usually also sometimes the first line, but may not be necessarily strong enough to address the underlying heart rhythm abnormality, in which case there are stronger medicines that may be used to address this. So again, the term tachycardia, it really depends upon what the tachycardia is due to, what the underlying heart rhythm is that's causing that tachycardia.
Thank you. Dr. Azifi, anything to add? I think you were chiming in, but you were on mute. Anything to add to that?
I should pretty much took the words right out of my mouth. I agree with everything she said. That's
okay.
Yeah.
Great. Well, Dr. Azifi, I did want to ask you a question just about just women in general and, how we are paying attention to our symptoms. We talked earlier about how busy we are. We wear a lot of hats. Do you find that women tend to ignore or explain away their symptoms that we've been talking about symptoms and risk factors? And what is your message to women about that?
Women oftentimes, wearing like a million different hats, right? Working, primary caregivers, huge emotional support, huge pillars of community. And so, our heads are usually in 10 different places, trying to take care of the kids, trying to, do the appointments for the kids. But then you ask, when was your last doctor's appointment? And they don't even have a primary care doctor, but they can give you the name of the pediatrician. They can give you, all the dates of the appointments. They can give you the name of the dentist and all that stuff for the whole of the family. But, they haven't seen a primary care doctor. And the only person they've seen is their gynecologist. And they never made, the effort. It's just, it's a lot of time, a lot of responsibility. And, so sometimes, and to be fair, not to be completely unfair to women, heart disease in women can be very, very tricky. It's almost like it can be very sneaky. We have situations where women say, I'm just fatigued, and that's all. There's no chest discomfort, there's nothing else. And that's the only symptom that they have, just profound fatigue. And somehow, going down the rabbit hole, it gets discovered that they do have heart disease. And so I guess, yes, we do try to, keep ourselves as the least priority and sort of take care of everybody else. And we do try to downplay symptoms, but there's also a component of it that the symptoms do tend to be very different from the way they present in men. So it's sort of more like a combination of things. How do you know if you're having reflux symptoms? That reflux symptoms can be a common presentation of heart disease in women, right? You think, I'm just going to take more Tums and take more antacids, and then next thing, a heart attack happens and the person's passed away. And the family actually hasn't had the opportunity to learn what has happened, which was that, the reflux mom was having all this time was really heart disease. So I would say definitely speak out. Don't accept symptoms as just things to live through or soldier through. Talk to your primary care doctor. They are there for a reason. They are trained and they can pick up on symptoms that you may dismiss. And sometimes it feels like when you go to a doctor's office, you're saying something and they're focusing on something else. It kind of comes from that sort of training. They know what is to be focused on sometimes, the things that are life-threatening and the things that may seem like they are very, they're very uncomfortable to feel on a day-to-day basis. Sometimes may not get as much attention, but I do feel saying everything that is happening to you and advocating for yourself and remembering that if you do not fill your cup up, you can't pour out to others. If you don't take care of yourself, just like the airplane thing where they say you should put the mask on first for yourself and before you put it on the child. If you're not here because you have heart disease and you pass away, your children are going to not have a mom. So it's very important that we remember that we do have to take care of ourselves first and we should not minimize symptoms. I think that's the general message I'd like to pass across.
I think I would also point out that, as was brought up by Dr. Jean as well, that most women, or I'd say people in general, think that they don't have symptoms when it's not specifically chest pain. It's like, I don't have, as was commented, I think earlier, it's not chest pain, it's a tightness. That's not the heart. And so one statistic that I read about was that out of every 3 women who died, 2 of them claimed they didn't have any symptoms at all. I think they're just not recognizing that the symptoms they're having could be from the heart. And I think, participating and reading up about this and being aware that the indigestion that you're having could be from your heart, and seeing somebody when you have these symptoms to kind of tease out, is this really indigestion or could this be from your heart, is important. But if you just assume one thing and you never seek attention for that, then that's where we get into trouble, I think. So I think just this increased awareness that it's not just because you don't have chest pain doesn't mean that it's not from the heart.
Those are all really good tips. What about the importance of going in and not delaying that care? I mean, you were kind of alluding to that already. I mean, this is, it's obviously it's your heart. It's an important, very important, maybe the most important organ in your body. And it's important to not delay care. What would you say to people who are either hesitant to go in and get care, or they are ignoring those symptoms or chalking it up to, I'm just tired because I'm a mom, or a wife, or I work a lot. Dr. Jean, anything to add to that as we wrap up the broadcast?
Yeah, I mean, definitely during COVID, that has been something we've been grappling with, where patients are so scared, understandably, but they're choosing to delay care or staying home longer or going to urgent care. But we have to remember, just like the brain, time is muscle, right? So time is, in terms of stroke, people sort of recognize the importance of early intervention, but it's the same thing for the heart. I personally was involved in the care of a patient who didn't come during the pandemic, and he needed to be put on a heart transplant list, which was something that, and this was for a heart attack. He having chest pain for several hours, didn't come until the next day. And that was the first time we saw this extensive damage from a decision to not come in due to the fear of the COVID pandemic. So we definitely want to avoid that. Thankfully, we have not been seeing a lot of these cases up until this pandemic, because patients were aware of the critical need to come early, because the sooner we can open up that blockage when there's a heart attack, the less damage that there is to the heart muscle, better survival, and less symptoms down the road. And so I've seen it many times. I've had to tell patients many times to go in, and usually they're worried about their spouse, who's going to take care of them, or who's going to watch the dog or something. But you have to put yourself on that number one to-do list, so that you're alive and healthy sort of heart condition to take care of your loved ones. And so the best thing is, you're not sure, it's not for you to figure it out. Don't WebMD, don't Google it. Give us a call, go to the emergency room, call 911. Really leave driving to the ER as your last resort. You should be calling 911 for immediate assessment, and then we'll do the testing and take it from there.
Thank you very much. Dr. Azifi, any other takeaways or anything else you want to make sure that our viewers get from this broadcast today?
Just quickly, just to say last thing about advocating for your health. Sometimes there is the experience that women feel like they're not heard during the doctor's visit. Making sure you feel free to ask questions, ask as many questions as you need, making sure you keep a repertoire of your own health history. As you can see, pregnancy and what happened during pregnancy is important to take note of. Menopausal history is important to take note of, and getting an accurate family history is also very important to take a note of, so that by the time you do see a doctor, you are more likely to be given all the information they need to have to take the symptoms you're having seriously. Because if we don't know you have the family risk, we are not going to assess you as someone who comes from a family of that background. And that may mean less testing and less investigation. So I think, having that as well is helpful in advocating for you to get the access to the kind of care you need.
Thank you very much. Dr. Srichai, any last takeaways that you wanted to share with our audience, something that is really important for them to take away about women and heart disease?
I think we talked about a lot of different things here. It's been a great discussion. Had great questions and audience participation. One final thing, which I meant to bring up at the beginning, but I want to definitely bring up now. I think women, when I talk to women, they're more concerned, and it's not rightfully so, about their risk for breast cancer. And I just want to point out, again, you brought it up that heart disease is the #1 killer in women. And it's actually the #1 disease as well as killer in women, and it's a 10-fold factor higher than breast disease and breast cancer. The deaths that breast cancer causes in women compared to heart disease. So I just want, as much as you're concerned about your breast, take all that concern and put it 10-fold amount in your heart.
Very good advice. Thank you. Dr. Jean, any final words from you?
No, I think this was a great discussion. Thank you so much for allowing us to have this time with you.
Yeah, same to you all. Thank you very much. It was a great discussion. I know we had a lot of information that we were able to share with our viewers, so I want to thank them for joining us. We did have a couple other questions that came in that will get answered by our experts, and we'll reply to those in the comments. And we also have a health risk assessment that we invite you to take to learn your risk for heart disease. So we're going to include that and a link to our website for general information about heart disease in the comments. Want to thank you again for joining us, and we hope you have a healthy, happy Heart Month. Thank you so much.